rationale behind this study, that is adding chemotherapy in patients that have metastatic disease since the onset of castration-sensitive prostate cancer, is that with the chemotherapy we are trying to kill pretty soon the cells that are already present being testosterone independent. This allows to kill this tumor population and also allows the chemotherapy being given earlier, meaning that usually the patients used to receive chemotherapy when developing castration-resistant disease, and at this point maybe the patient is quite frail, so giving chemotherapy earlier, probably the benefit is obtained since the very beginning, not need to wait until the patient develops a castration-resistant disease. Also, there is another rationale that has been demonstrated in this trial, that the time to develop castration-resistant disease might be prolonged. And in this trial, we have seen today that in fact those patients, it takes longer to develop castration-resistant metastatic prostate cancer. And this trial accrued 800 patients that were randomized to the two arms, and mainly those patients need to have a specific characteristics that is highly aggressive tumor burden, meaning having visceral disease or having more than 4 bone metastases, and one of the bone metastases need to be outside the pelvis or the axial skeleton. Overall, the overall analysis showed that there is a benefit of 13 months in survival for the overall study. When we are focusing on those patients being high risk, we see strikingly 17 months survival benefit in the median. So this is a huge amount of benefit. This trial was started in 2006, and we know that it's now 10 years when at ASCO, at the plenary session, the results of docetaxel in castration-resistant prostate cancer patients were presented. And the survival benefit with these patients having castration-resistant was only 2.5 months. And now we see this striking benefit of 17 months in the subgroup of patients having a high tumor burden. So these results probably are practice changing in those patients having high volume metastatic disease. Adding 6 cycles of chemotherapy to ADT, providing this huge survival benefit, obviously merits to add the chemotherapy in a specific subgroup of high tumor burden. Obviously, we need to wait for longer follow-up for these patients that do not have these characteristics, more than 4 bone mets or visceral disease, and maybe the benefit is going to be seen with a longer follow-up. So the treatment burden that means adding 6 cycles of chemotherapy is worth when considering the survival benefits that have been seen, and those are the higher survival benefits never seen in any prostate cancer trial, even with abiraterone, enzalutamide, docetaxel, cabazitaxel, radium-223. So it's a huge impact in survival. In terms of the next steps after the results of this study have become available, is obviously try to collect additional follow-up in those patients that have low tumor burden. Also, there are several other trials. The JETUC trial that was published last year in Lancet Oncology, and that didn't achieve this survival benefit. The main reason patients included in the French trial were patients that didn't fulfill these clinical characteristics of being metastatic and high tumor burden. And maybe the number of events required to obtain a survival benefit, you need to wait so much time and other competing causes of death may have hampered the possible results in terms of the survival. One of the steps that are going to be done is to collect different data sets of patients, that there are so many trials that have been adding chemotherapy in this period of hormone-sensitive prostate cancer, and putting all these patients together, probably we are going to enhance the benefit and establish or reinforce or reassure that these patients with these specific clinical characteristics are the ones that will require adding chemotherapy.